Hello, everyone, and welcome back to SALT Talks. My name is John Darcy. I'm the managing director of SALT, which is a global thought leadership forum and networking platform at the intersection of finance, technology, and public policy. SALT Talks are a digital interview series that we launched during 2020 with leading investors, creators, and thinkers. And our goal on these SALT Talks is the same as our goal at our SALT Conference series, which is to provide a window into the mind of subject matter experts, as well as provide a platform for what we think are big ideas that are shaping the future. We have another great talk focused on community impact and philanthropy and science today. And when we can find that intersection, that's really the sweet spot that we like to cover here on SALT Talks. And our guest today is Dr. Jonathan Simons. Dr. Simons is the president and chief operating officer of the Prostate Cancer Foundation, PCF, which was founded in 1993. And it focuses on research and resources for a disease that 1 in 9 American men will be diagnosed with in their lifetimes, and which also claims 34,000 lives each year. Just as a quick personal anecdote, my father had prostate cancer and was cured and has lived many years beyond that. So thankful for the work of Dr. Simons and his team at the Prostate Cancer Foundation on that piece. But the fight is personal to Jonathan as well, who is the husband, son, and grandson of cancer survivors. He's board certified in internal medicine and medical oncology. He received his medical degree from Johns Hopkins University and did his residency at Boston's Mass General, as well as a clinical fellowship in medical oncology at Johns Hopkins Oncology Center. Before joining PCF in 2007, he was the Distinguished Service Professor of Hematology and Oncology at Emory University School of Medicine, my alma mater, and Professor of Biomedical Engineering and Material Sciences at Georgia Institute of Technology, Georgia Tech. Dr. Simons is the founding director of Emory's Winship Cancer Institute and co-director of the National Cancer Institute Center for Cancer Nanotechnology Excellence at Emory and Georgia Tech. Hosting today's talk is Anthony Scaramucci, the founder and managing partner of Skybridge Capital, a global alternative investment firm. And he's also the chairman of SALT. And with that, I'll turn it over to Anthony for the interview.
John, thank you. And Dr. Simons, thanks for being here. You know, you mentioned cancer and cancer survivorship. It's obviously all very personal. Your grandfather survived. I believe your dad was one of the first people treated at the National Cancer Institute for lymphoma and was cured or put into remission. Your wife is a cancer survivor. My wife is actually a cancer survivor. She had bladder cancer at the young age of 21, which was sort of hard to believe, but they say it was related to drinking water around the Love Canal where she had gone to school up in Buffalo, University of Buffalo. So we have cancer in our lives. Unfortunately, just about everybody listening has a cancer story. Tell us about the journey that brought you to your cancer research.
Well, my story, like so many stories, is not that unusual. 1 in 3 American families will experience cancer. And I'm glad, John, your dad's doing well, and I'm glad, Anthony, your wife's doing well. But what was formative for me is my father was cured after relapsing several times from Hodgkin's disease on a clinical trial. So as a kid interested in science, if I couldn't make it to the Major League Baseball career. And I thought basically cancer research was heroic. And because I literally saw the curability of an incurable illness kind of unfold in our lives. And my father recurred several times. So he faced an existential threat. But I think that's a story that so many families can tell in different ways, but that's really mine. So I was interested in being a doctor and a cancer scientist and developing a treatment, and got very interested in prostate cancer as a consequence of a baseball coach who got prostate cancer before there was a blood test to detect it, and who succumbed in under 12 months of diagnosis. So I got interested in prostate cancer because I was interested in seeing prostate cancer go the way of Hodgkin's disease, which went from incurable to curable.
You know, this is an interesting disease. I'd like you to lay it out for people. It's obviously a male disease. Breast cancer is probably 97% women, but there's a small percentage of men that also get breast cancer. But yet this is a male disease, treatable. We have way more understanding of it as a result of your research. So take us back to 1993 when you were awarded, as a scientist and a doctor, you were awarded a research grant from the Prostate Cancer Foundation. What were you researching then? Where are we today? Build the continuum for us.
Sure. So you're right. Prostate cancer is the most common non-skin cancer in men. And basically 1 in 8 men and actually 1 in 6 Black men will get prostate cancer in their lifetime, even though now it's, if caught early, the 10-year survival for prostate cancer is 98%. But in 1993, it was woefully behind, given the amount of it and this, basically the public perception that it was a disease of old men. It took somebody to change the equation, and that was 40-year-old man named Michael Milken, who was diagnosed with prostate cancer, told he was terminally ill. He sounded pretty good on the phone yesterday. And he said, I'm going to change the course of medical history and accelerate work on this cancer. And really, Mike invented, as we now really understand it, entrepreneurial or venture philanthropy for cancer research. But basically used every relationship he had, used his entire Rolodex in order to try to assemble partnerships between philanthropic support, biotech and pharma investment, and significant government investment to basically deliver new treatments and better detection. And really, if you're looking at return on investment, and I know your viewers are interested in ROI and a lot of things, there's been, since Mike was diagnosed, a 53% reduction in the death rate from prostate cancer. John, your dad's a part of the story, right? That's the largest decrease, absolute decrease in death rate in any of the major cancers. And that's a consequence of a heavy investment in research, public awareness, and partnerships. But we must still do better. An African-American man is still twice as likely to die of this disease as a white man in the United States. And for every man in his family, we have the opportunity in this decade to really put prostate cancer in the rearview mirror as a major public health threat. But prostate cancer hasn't stopped in the pandemic, and neither is prostate cancer research or our foundation.
Tell us about ways men need to think about it. How do they potentially prevent it? Michael Milken obviously has come to our SALT events. He's spoken many times, once in Singapore, a few times in Las Vegas. He's always talking about nutrition. Dr. Simons, tell us a little bit about what men can do to protect themselves. Obviously the PSA test, et cetera, but give us a portfolio of things that people can do.
There are 3 things that a man could do. They can talk to, excuse me, they can talk to their family about risk, because in the same way you put on seatbelts because there's a risk of a car accident, they can talk about risk. They can get screened. I can talk more about that. And they can really take charge of the future of their health. And the way to do that is assume that you're very likely to get the disease and you'd rather live into your 90s and not die from it. Second, it's 57% of prostate cancer runs in families. It's actually the most inherited of the major cancers. So at 40, if you have prostate cancer running in your family, not only do you need to get checked, you need to be checked at 40. And certainly if you're African-American, given the fact that you have a higher lifetime risk of getting the disease, you need to take charge of your health once a year and basically have a conversation with your doctor at 40 if the disease is running in your family, at 45 if you're African American, and we believe at 50 if you're of European descent. Those are the three things. And, basically prostate cancer is to men as breast cancer is to women. We just have to assume far more family interest in our health as men as women do in caring for families and caring for themselves.
When you look back, is there anything in the prostate cancer research that you've done that has led to transformations in the research of other cancers?
Yeah, I'm grateful for that question because it's a really important one. The discovery of checkpoint inhibitors that have made melanoma curable, it extended the lives, in the Super Bowl, you hear about treatment for lung cancer using the immune system. That discovery was made by James Allison and won a Nobel Prize, but was originally funded. First real foundation support was from the Prostate Cancer Foundation, asking the question, how can you turn the immune system on against prostate cancer? So in fact, we've delivered 13 FDA-approved drugs, which have significantly extended the survivability of prostate cancer over the years with $800 million in R&D that our foundations invested. But we've really pushed forward rather profoundly progress in over 11 other cancers. And cancer research is just not a zero-sum game, particularly as we've come to understand how genes work. And right now we're really prosecuting research on new drugs that target prostate cancer, ovarian cancer, breast cancer, through a gene called Wnt, pancreatic cancer, colon cancer. And in fact, in curing prostate cancer with these new genomic or gene-based medicines, in curing prostate cancer by making these new precision medicines, you're really talking about finishing off 73 other forms of human cancer, including childhood brain tumors. So there's one of the things that my community doesn't do very well is market itself, because it's much more interesting to talk kind of nerd to nerd about how interesting these genes are. But fundamentally, this revolution in understanding how genes work through the human genome and then making medicines against genes that are rogue and aberrant in cancer means that cancer is no longer just anatomic. Cancer care isn't just where the cancer came from, it's genomic. It's making medicines against the genes. And in the next few years, we're going to see extraordinary progress. This isn't Pollyannish, and basically making new classes of medicines that are going to treat the genomics, not the anatomics. So we'll see FDA approvals, not so much based on did the tumor come from the breast or the bladder or the prostate, but against really the Achilles heel, the genetic Achilles heels of these tumors.
Let's talk about this, the money raising aspect of this and how important it is to your research, and give us a sense for who is underwriting cancer research today. Is it mostly private citizens and foundations and drug companies? Is the government also in there? What does the mix look like now in terms of the R&D going into these things?
The ecosystem has three major investors, and they're all vital to each other, and they're codependent if the goal is to end death and suffering from cancer. Foundations like ours can often make the higher risk, most in first kind of like Series A round, insightful investments. Our National Institutes of Health, our National Cancer Institute, the Department of Defense invest millions in maybe perhaps in thinking about validating or Series B and C or expanding on a discovery. So philanthropic support, although it's only 4% of the pie, it's some of the most essential of all the investments, because it can be more nimble, and it can identify what we would call breakout opportunities, Anthony. But biopharma is essential in scale. There are extraordinary and healthy partnerships. Mike Milken and others really developed a new kind of ecosystem in the 90s and 2000s. When I started at Johns Hopkins, we were told never to go to a drug company research meeting because we were pure and they were purely profit driven. That whole culture sort of evaporated with the excitement of university scientists and project managers and biopharma trying to accelerate getting a scientific development to patients. And our government, probably one of the things that our country still leads the world in, regardless of your views on American exceptionalism, sorry, but just the way it works right now with COVID. Regardless of your view, your views about American exceptionalism, we've been an exceptionally generous people at funding basic research. I mean, one of our greatest exports, I think, is actually medical progress. And our National Institutes of Health, and you saw it with the development of COVID vaccines at just, meteoric speed. But that meteoric speed in developing these vaccines is happening in cancer research all the time now. But our NIH has just been a huge partner in the reduction of deaths as well. It doesn't mean that getting funded for a breakthrough idea is easy. It's actually harder, and it's going to be harder in the COVID economy probably. But it's a proven ecosystem, our cancer research ecosystem. It just has lots of areas where we could still now go faster if we concentrated on solving some of the problems and choke points. And a really good example of that's an African-American detection, basically an African-American disparity or health justice. Robert F. Smith made an enormous philanthropic commitment this year to accelerate the development of a test. You could test blood or you could test saliva to identify African-American men, really men of West African ancestry, that have a 2 to 11 times higher chance of getting prostate cancer. And this whole idea of transforming even how we screen for cancer by understanding genetics, it is built on NIH funding and trying to understand how genes work in family, but also an impatience for true health justice and trying to invest now in the actual development and testing and final really reduction of practice in communities of color. So the entrepreneurial philanthropist still is the most important part, we believe. Entrepreneurial donors, entrepreneurial biomedical research foundations, we think are still the vital driving force, where there's 10x from the government if you can move along the data. That was a long nerd answer.
No,
I get cranked up on this topic because
no, I let you go because it's so interesting. Our resident millennial, Dr. Simons, is dying to ask a question here, so I have to put myself on mute. Don't let him outshine me, however. Okay, try to talk over him.
That's impossible. My IQ is not nearly high enough relative to our guest here today. But just to go back to what Anthony said, we can't give Michael Milken enough credit for the work he's done as a venture philanthropist in the field of medicine. He has done so much. I don't think people realize how much capital he's driven into the space and the outcomes that it's generated. So we're very thankful to him. But I have a question. The New England Journal of Medicine noted last year that the pandemic threatened public health, not only because of the risk of COVID, but because of its effects on patients with other diagnoses, including cancer. It could be because risks of immune compromised people visiting offices, for example. Mm-hmm. How does the data show that playing out over the past year?
There's no question that we don't have all the data on how disruptive COVID-19 has been in terms of delaying the standard of cancer care. I'm sure it will be unhappy. It's made it very, all I can do is speak from my own small but real practice of prostate cancer oncology and talking to colleagues. It slowed down getting surgery or starting radiation, just the logistics of getting patients in and out and tested because we're trying to stagger them. And What's been very challenging is it's slowed down clinical trial accrual for cancer medicines that may be breakthrough medicines or really be very important part of developing new therapy. But the good news is that I think cancer patients have learned that telemedicine is here and that it may be possible to develop ways of actually more efficiently and actually more compassionately interacting with patients using telemedicine on a lot of issues that until COVID we wouldn't have considered. The key is going to be getting herd immunity established as soon as possible so we can get further and further towards sort of the normal patient flow. And no question as well, cancer screening rates are down, but I don't know what they are most recently. And we're very concerned about that. And particularly in lower socioeconomic environments and communities where we're so concerned about improving cancer screening rates.
Yeah, it's a problem that obviously the COVID-19 pandemic has had a disproportionate negative impact on communities, people of color. We talked about that with Paula Schneider of Susan G. Komen, and it's rampant across a variety of different diseases and circumstances. But President Biden is arguably more dedicated to cancer research than any president that we've had in the history of the country. How optimistic are you that we could take a giant leap forward? And from a public policy standpoint, what would you like to see done that hasn't been done before, or maybe has been done, but not on a large enough scale to accelerate progress that we're making in cancer research?
Well, first of all, I think you're right. I think President Biden will be the most nonpartisan or bipartisan champion of accelerating progress against cancer. And we've had some presidents that have experienced cancer in their families for certain. I worked directly with Vice President Biden and his staff, on the Vice President Biden's cancer moonshot. And actually, I have a very specific answer. We think that our program with the Veterans Administration and delivering precision oncology. So if you're served your country first, you should be first to get cancer research breakthroughs for prostate cancer. We think that in this administration, not only will medical care and cancer care really improve in the Veterans Administration, but there's an opportunity to take the nation's largest health system with actually the best electronic medical record and really push forward how clinical trials are delivered, how we basically learn how to deliver precision care for all forms of cancer. And second, I think President Biden's going to be a champion of basic cancer research or basically fundamental discoveries that could bring breakthroughs in earlier detection or medicines. But also, I think this administration's can be very interested in all the choke points. What's slowing us down? Well, the ease of letting rural Americans take place in clinical trials, or Americans in urban areas take place in clinical trials. Because right now, only 4 in 100 Americans are taking with cancer or even participating in a clinical trial. So even if we got that to 20%, that would be 5 times as fast as delivering to the FDA, packages of data that show benefit. And last, I think this administration is a real champion also for the important role of nursing, and our system needs to readdress the in our healthcare system in particular, how vital for the future health of our country nursing is, and particularly advanced practice oncology nursing. And here I am, a physician scientist talking about nursing, but I think that these are going to be very positive developments.
Yeah, and how has sort of data improved and our ability to process data relative to cancer? I feel like we talk to a lot of people in the healthcare space, and they talk about how we haven't, because of legitimate rules around privacy and things like that, haven't been able to sequence enough data, large enough data sets to really make huge progress. I had somebody I knew in New York. Their brother was a founder of Flatiron Health, which you might be familiar with, backed by Google, acquired by Roche, that was trying to gain greater access to that data and process that data in a more effective way. Are you optimistic about breakthroughs in data processing as it relates to oncology generally?
I'm aspirational and hopeful. I feel sort of like the way we handle data in medicine is sort of like January 1942 after Pearl Harbor. We had a Navy prepared for the last war, right? We only had, 4 aircraft carriers, even though air power was going to be the essential element for for winning the war against the fascists. We all know in oncology, we all know in medical research that the silos of data right now between the laboratory and the clinic and data scientists are woefully antiquated, given the opportunities. If you can sequence the human genome for less than 1/3 the cost of a CAT scan, but you can't get that information to a doctor and to a pharmacist and to researchers. Just look at our challenges right now with sequencing COVID. Basically defining the genetic. This is like a surveillance problem that's trivial in terms of its genomics. But just look right now at our public health system's challenges in terms of assembling data on variants. I'm hopeful that we completely reevaluate how we can protect patient privacy, but also put the patient first from the standpoint of getting the benefits of all this scientific and medical knowledge. And our electronic health records are geared to paying currently our electronic health records are designed for reimbursement. They're not designed to ideally care for the next patient based on the science we know. So we're going to have to put patients again first in terms of how we think about big data, and we're going to need to allow data to be analyzed by all kinds of people in ways where we protect privacy. So in the long term, I'm optimistic, but we haven't seen, while there's been a lot of talk, we haven't seen a great example yet of a fully integrated health system. And again, I'm cranked up about this. That's why we're so optimistic about the Veterans Administration, actually, because they actually collect outcomes data independent of reimbursement. I'm not saying reimbursement isn't important, but what I am saying is that we need a complete redesign in how we look at medical data and allow data scientists to make these important observations.
Well, I could ask you a lot more questions, but I'm going to turn it back over to Anthony to see if he has any final words before we let you go, Dr. Simon, so you can get back to your important work that you do every day.
Well, my question is about the future, Doc. You seem like you're on the cusp of a lot of breakthroughs, and you seem like you've helped to integrate the narrative around cancer therapies with other types of cancers through your research. So where are we 5 and 10 years from now, if things go well? Build us an optimistic case, if you don't mind.
I am optimistic based on the facts. There'll be no clinical decision without precision. Your genes will be sequenced, the expressed RNA will be sequenced, and we'll be treating the right patient with the right drug at the right time, or making the right clinical decision based on an extraordinary understanding of the disease that you have. Second, if we can solve our access to care issues, if we can solve basically the delivery of these amazing things, I see a real steep drop in cancer deaths by the end of the decade, because we're also going to be doing precision detection like this Robert F. Smith test or the polygenic risk test effort. Basically, we'll be able to, pediatricians will be able to help families understand their lifetime cancer risk. And getting back to nutrition, we'll have a very good understanding of food as medicine, not trendy thinking as medicine, but we'll have kind of the core metabolic understanding of what makes a healthier lifestyle. And then we'll have apps I think reinforcing products to allow us to really live healthier lives. I actually think that this is not only going to be the greatest decade in the history of medical research, just the breathtaking speed of the COVID vaccines, or the fact that we had 7 FDA approvals in the midst, hidden in plain sight with COVID. We had 7 FDA approvals for prostate cancer, which is a record year, all really driven by, again, sort of early stage funding by our foundation and then leverage by the government and biopharma. I think it's going to be a decade where patients will be partners in their care, whether they're millennials, John, or not. I think health apps and a general understanding that with good health information, you can be a partner in your care is going to actually improve the care of everyone. So I'm actually very optimistic about the decade if we can just, if we can just stay very focused on supporting cancer research, and more broadly, biomedical research is one of the most important humanitarian things we could be doing in this country for the world.
Before we let you go, you mentioned the vaccines. So have you been vaccinated, doctor?
I have.
And are the vaccines safe?
Yes. That's what the data says.
Okay. And so, but what would you be concerned about? Because we have, just play this out for me, because we have people that are concerned about the vaccines. The data says they're safe. Do we need more data, or was the data acceptable for you to get yourself vaccinated? So tell us what you think.
We need more data in areas where we constantly need more data. In fact, what we need is a learning health system. That would have been the punchy answer to your big data question. So we need a lot more data, but by everything we know, it's much better to be vaccinated than not. And we're not over coronavirus infections, as the variants show. So we need to become confident again that our health systems and our biomedical research efforts keep good ethical values, but are trying to basically save lives.
Well, no, I appreciate it. Unfortunately, we are in the age of tremendous amounts of information, but we're also in the age, unfortunately, of tremendous amounts of disinformation. And so you and I, John, Michael Milken, we're believers in science matters and facts first. And so would you recommend this vaccine to your patients and family members?
I am.
Okay.
Actually, Anthony, you're very articulate. You're a student of history, and you know that at any moment in history, there's more that's unknown than known. So we have to be comfortable with continuing to learn about this disease, but we also have to be comfortable with evidence. And the evidence from randomized clinical trials, which is our best way of doing this, not the fastest way is to do this, is the best evidence is to be vaccinated, to prevent yourself from dying of COVID-19 and spreading it.
Amen. All right. Well, I want to leave it on that. I think it's an optimistic note. We don't know everything, but we are advancing, and we're doing the best that we can. It's in the best interest of our citizens and our society to get vaccinated. It'll protect them against the pandemic and future potential variants, et cetera. Anything else you want to add, Darcy?
That's it. Just want to thank
Dr.
Dr. Simons.
Peter or something like that before he leaves?
No,
because there's a P
a little more straightforward.
There's
I'm
a
not going
P
to
in
call him.
prostate. So do you want to call him Peter before he leaves, or just ask?
I think I got this one nailed down.
Okay,
my
just check.
gaff with Paula Schneider of the Susan G. Komen Foundation. But I just want to thank you, Dr. Simons, for all the work you've done. My father's one of millions of people. He's both a prostate cancer survivor and a skin cancer survivor. So all the research that you've done, both directly related to prostate cancer as well as the other cancers that you and Anthony were speaking about earlier, it's allowed him, this is more than a decade ago now, to live a long, healthy life. And he's now been vaccinated. So we hopefully don't have to worry too much about coronavirus with him or my mother as well. So thank you for all the work you're doing.
Well, thanks for the time today, and good luck with delivering the truth to people.
We're working on it every day, sir. It's a work in progress every day.
It has been since the dawn of man.
Amen. Amen. It's getting a little bit tricky now, man. We got a lot of different disinformation out there that we're trying to fight back.
Well, good luck with that.
But thank you again, Dr. Simons. And thank you everybody who tuned in to today's SALT Talk. Just by tuning in and learning and spreading awareness of the progress that's being made, as well as the facts on the ground, you're doing a service not just to yourself and your family, but to society as well. So if you have the means to donate to the Prostate Cancer Foundation, please do. You know, we always put our money where our mouth is and contribute to these causes that we feature here on SALT Talks. And if you're able to do so, please do. If you can't, protect yourself and protect your family. You know, go get checked, go to the doctor. If you have a history of cancer in your family, you especially need to get checked frequently, but encourage family members and friends to get checked as well, and encourage them to follow the facts and get vaccinated and get checked for a variety of different diseases. But thank you for joining us. Just a reminder, if you missed any part of this talk or any of our previous SALT talks, or want to sign up for our upcoming talks, you can do all of that on our website at salt.org/talks. You can also subscribe to our YouTube channel, where we host all of our videos for free to try to broaden access as much as possible to these ideas that we feature here on SALT Talks on a variety of issues. And please follow us on social media. We're, as well as being on YouTube, on Facebook, on Instagram, on Twitter, on LinkedIn. And on behalf of the entire SALT team and Anthony, this is John Darcy signing off from SALT Talks for today. We'll see you back here again soon.